Good morning, doctors, and first of all, I would like to thank my Anna Vijayakumar for giving me this excellent opportunity in this 3D faculty and for the introduction by Dr. P Selvapandian, teacher of teacher. Thank you, sir, for your kind introduction. And I think my topic is, I think there will be overlap between my topic and Periandro is almost finished most of the topic, but still classification, I will make it so simple. I will not touch everything into the classification. I will say what is the relevant in our practical practice. That's what I'm going to talk. So classification, we all know type 1 diabetes, type 2 diabetes, gestational diabetes and secondary diabetes, that's all. But still, you should know type 1 diabetes, it's an autoimmune beta cell restriction usually leading to absolute insulin deficiency, including latent LADA diabetes, and type 2 diabetes due to non-autoimmune progressive loss of adequate beta cell insulin secretion. That is the most thing we see in 95% of the population, diabetic population in India. Only 2 to 5% is type 1, and specific types due to other causes, monogenic, that is MODY, and neonatal diabetes, maturity onset diabetes of young, disease of the exocrine pancreas, that is cystic fibrosis and pancreatitis, and drug-induced like glucocorticoid and other HIV and AIDS medications, and gestational diabetes you all know very well. And in type 1 diabetes again there is 3 stages are there, stage 1, stage 2 and stage 3. In stage 1 it is autoimmunity, stage 2 also autoimmunity, stage 3 also autoimmunity, but in stage 1 it is normal glycemia, there is some dysglycemia in stage 2, and stage 3 there is overt hyperglycemia, that is diabetes. And again it is pre-symptomatic in stage 1, again stage 2 also pre-symptomatic, in stage 3 only it is symptomatic, and autoantibodies everything is there present in the stage 1, stage 2, but it will not be present in the stage 3, most of the time it is absent. But stage 2 and stage 3 is very important, and I will tell you in the next few slides. So criteria for diagnosis you all know very well. Fasting if it is more than 126 and postprandial if it is more than 200 it is diabetes, and fasting if it is between 100 to 125 it is pre-diabetes, and postprandial if it is more than 140 to 199 it is pre-diabetes. In HbA1c 5.5 less than 5.5 it is non-diabetic, and 5.7 to 6.4 it is pre-diabetes, and say above 6.5 it is diabetes. And A1C again, this is a thing Dr. Periandro was insisting on this, and it should be A1C should be certified by a National Glycohemoglobin Standardized Program, and it should be standardized by the Diabetes Control and Complication Rate DCT assay. So with this only HPLC method, highly purified liquid chromatography is the method which is being authorized, but I am telling you most of the labs, local labs, they do the other method because it is very cheap, just 70 rupees for it will be the cost, but they will be charging the 450 only, but don't believe in that. And again point of care, again like Periandro told, it has to be approved by the US Food and Drug Administration approved devices, only then we can go with the, because point of care is very easy. When the patient comes to the clinic, you not wait for the thing, anytime you can see, but that requires specific temperature, room temperature, everything is necessary. So it has to be approved by the US FDA approval. And again marked discordance between A1C and plasma glucose means again possibility of A1C assay interference will be there, so that is also very important. Not all the labs, high tech and other things, they have a lot of interference in this thing, so we have a lot of difficulty in really assessing, because first day you will be taking 7.2, second day it will show 9.4 also. This is the proper possibility, so you have to be very careful. And again hemoglobinopathies and other things, sickle cell anemia, other things, they are also in pregnancy. Don't delay on HbA1c. It is only the fasting plasma and postprandial is a very important thing. And again, adequate carbohydrate. Before doing a OGGT, previous 3 days they should have adequate carbohydrate, that is 150 grams per day. That is very important. They should not come after fasting or something. They will be coming after Ramzan or something immediately. Don't do that. GTT. It has to be the regular 150 grams of carbohydrate per day. And type 1 diabetes, screening for pre-symptomatic type 1 diabetes using screening tests. As Periandro was telling, GAD antibody is very important, but this is all only for the research purpose and for first degree family members who want to know what is the probability of getting diabetes, that's all. So not for everybody, not in our clinical practice, don't do it, rely on this. And multiple islet antibodies is a risk factor for clinical diabetes, that is for the persons who are having type 1 diabetes, if they want to know what is the chance of other siblings or other thing to get diabetes, then you can go for this test. And again, screening for pre-diabetes and type 2 with informal assessment of risk factors or validated risk calculators should be done in asymptomatic adults. That is B recommendation. And testing for pre-diabetes and type 2 diabetes in asymptomatic people should be considered in adults of any age with overweight and obesity. This is an important risk factor, overweight and obesity. Do for everybody. That's what I think Dr. Pannisalam will agree. And again, for all people, screening should begin at the age of 35 years, very prompt. This is very, very prompt. For everybody you have to do, because ethnically and regionally, we are prone for diabetes. That's what the thing. So we have to do for everybody. And if the tests are normal, repeat the screening for at least 3 years interval. If there is any IGT or IFG, then do it every year. That's the recommendation, simply. And to screen diabetes, 75 gram oral glucose tolerance test is thing. Glucose unhydrated is not available. We can use the normal glucose of 100 grams for a routine clinical OGTT. That is the thing. And that's what I told, 150 grams of carbohydrate previous 3 days is very important before doing GTT. And in people with pre-diabetes and type 2 diabetes, identify and treat cardiovascular risk factor. That is the important message I want to. Weight reduction and cardiovascular renal risk factor has to be reduced. That is very much possible with our current treatment. That's the important message I want to convey from this diagnostic classification. And when to do this screening, onset of puberty or after 10 years of age, whichever occurs earlier in children or adolescents with overweight and obesity, and who have more than one or more risk factors for diabetes. And people with HIV, before starting antiretroviral therapy and after starting antiretroviral 3 to 6 months, again you have to repeat this investigation. This is a criteria I told, everything is a thing I will discuss. Criteria defining pre-diabetes, I told 100 to 125, but the ADA will be telling 110 to 125, but our thing is 100 to 125, and postprandial 140 to 199 is the criteria. And this is a risk chart. Many things are available, but still it gives a lot of validity to identify who's at risk. So cystic fibrosis, again, it is a thing, 1 lakh per 1% only is there. But again, annual screening for cystic fibrosis related diabetes with an oral glucose tolerance. Here you have to not rely on diagnostic criteria for diabetes. You have to do a OGTT, and HbA1c is not reliable at this for cystic fibrosis. No HbA1c, it is only OGTT. And I told A1C is not recommended and should be treated with insulin to attain. These people can't be treated with OHA, only insulin is the treatment. That is one more information. And after 5 years, only like type 1 diabetes, you can go for checking for any complications. After 5 years of cystic fibrosis only, you can go for microvascular and macrovascular screening. Post-transplantation diabetes, again, after organ transplantation, screening of hyperglycemia should be done, and the oral glucose tolerance is the best method. After stabilizing the patient after organ transplantation, then only you have to do OGTT, not immediately. And immunosuppressive regimen shown to be provide the best outcomes for patients, and graft survival should be used. So immunosuppressants also should be very carefully used in these patients. That's the important message. And monogenic MODI, regardless of current age, all people diagnosed with diabetes in the first 6 months of life would have immediate genetic testing, and these all can be done, as Dr. Periyakumar was telling. It should be in the consultation with the center specializing in diabetes genetics is recommended to understand the significance of genetics. So we need not worry about this. This has to be referred promptly to a center who's doing a genetic thing, other things and all. So not everybody can do this. Only some specified centers are there. Only they can do. Again, these are the genes and inheritance, and most of these MODIs respond for sulfonylurea. That's what I want to, important message from this. Most of these MODIs respond for sulfonylurea. So don't go for insulin in these cases. Try with thing. So the diagnosis of monogenic diabetes should be considered in children and adults diagnosed with diabetes in early adulthood with the following findings. Diagnosed with the first 6 months of life with occasional cases present later. Mostly the gene INS and ABCC8 mutation. These are the genes mostly involved. And diabetes is the typical features of type 1 and type 2 diabetes. This is the common thing we face, in some atypical patients, They don't have any features of type 1 or type 2, negative antibodies, no obesity, lack of other metabolic features also. Especially the strong thing is family history will be there. Father, grandfather, everything will be there. So in that case, please hold, that is a MODI. And stable, mild fasting hypoglycemia, and this is also. And these people does not need any treatment at all. That's an important message in this thing. And gestational diabetes, as Dr. Periyakumar was saying, if they are planning for pregnancy, see for the risk factors. What is the risk factor? Whether they are obese or in their family, their sisters are having abortion and other things. These are the risk factors. Try to, in those individuals, you can do a screening. And before 15 weeks of gestation, some people, they are worried their elder sister would have got some problem in the pregnancy or something. In those patients, go with the OGTT and start them on insulin. Not for every 15 weeks of gestation, not for everybody. Other patients can be treated with OHA, but in these patients, insulin gives some benefit. And individuals with childbearing potential identified as having diabetes should be treated as such. That is an important thing. That is recommendation A. So you don't leave these patients because they are going to be going for gestation. So you have to treat them and prevent the complications. And again, before 15 weeks of gestation, screen for abnormal glucose metabolism who are at higher risk of adverse pregnancy and neonatal outcome, because you can know these patients will be having outcomes will be bad. In those patients, they require insulin and they have to be on insulin, but the recommendations give E. There might be some benefit because still some gynecologists believe OHA will be enough, metformin will be enough, but that's all. Still it is a dilemma, but still there might be some benefit. Then the recommendation E. And abnormal glucose metabolism using fasting glucose is very important. And screen for gestational diabetes at 24-28 weeks. This is a general recommendation in pregnant individuals not previously found to have diabetes. And again, screen individual gestational diabetes in a test for pre-diabetes and diabetes at 4 to 12 weeks postpartum. This is a thing where everybody misses. Every doctor misses in this thing. So please, this is a recommendation I want to highlight. Please, in the gestational diabetes, after 4 to 12 weeks, please check them with OGTT. That's an important thing. And again, individuals with history of gestational diabetes should have a lifelong screening for the development of diabetes or pre-diabetes. Again, here also we miss this patient because they will say in pregnancy I had, after that everything cured. No, please follow. 60% of chances are there to become a diabetic in these patients. And individuals with history of gestational diabetes found to have pre-diabetes should receive intensive lifestyle intervention and metformin to prevent diabetes. Again, recommendation is A. See the thing. So if you are starting on a metformin, don't bother. Even the patient will say, I don't have diabetes, why I should be on metformin? Please, recommendation is very strong, it is A. And GDM I told one step and 2 step, Dr. Perindra was telling. See, one step means 75 gram glucose, plasma to give 1 and 2 hours at 24 to 28. 1 hour should be if it is more than 92, and 1 hour if it is more than 180, and 2 hours 153. They are called as gestational diabetes. And 2 step, first you have to do 50 gram glucose, and after 1 hour you have to see the reading. After 1 hour, if it is more than 130, 135, 140, you have to do a OGTT. That is the second step. And the second step, you have to do 1 hour fasting, 1 hour, 2 hour, and 3 hour. These are the readings. 1 hour if it is more than 95, 1 hour more than 180, 2 hours more than 150, and 3 hours 140. They are called as GDM. Thank you.